Streptococcus pyogenes, also known as group A Streptococcus, is a high-yield topic in that infection with this organism can cause a variety of complications, like for instance rheumatic fever, acute post-streptococcus glomerulonephritis, streptococcal toxic shock syndrome, as well as scarlet fever. And so examiners can ask you details about any one of these complications or provide you some of the phenotypic features of any one of these complications and then ask you about the features of the underlying infectious organism. So what I'm going to do in this video is that I will talk about the features of Streptococcus pyogenes, about the cellular components that will lead to any one of these complications. And then after that, it would be much easier to be able to understand the features of any one of these complications and also to link them with Streptococcus pyogenes as an underlying infectious agent. So Streptococcus pyogenes, also known as group A Streptococcus, can cause either pyogenic or non-pyogenic complications. And pyogenic complications, for instance, include tonsillopharyngeal abscesses. It can also cause otitis media, sinusitis, cellulitis, as well as impetigo, which is a skin infection that presents with honey crusting lesions over the superficial skin. And this type of condition, impetigo, is also caused by another organism. And could you tell me what other organism can also present with impetigo? And the answer is Staphylococcus aureus. So both Streptococcus pyogenes and Staphylococcus aureus can cause impetigo. And then the non-pyogenic complications include, for instance, rheumatic fever, glomerulonephritis, toxic shock syndrome, as well as scarlet fever, which I will discuss it after I go over the cellular components of the Streptococcus pyogenes. Now, in terms of features of this infectious organism, Streptococcus pyogenes is a gram-positive cocci that grows in chain. So here you can see the cocci that are growing in chain, and then they are also sensitive to the bacitracin. So if you add bacitracin to the culture media, the Streptococcus pyogenes would not be able to grow. And then the other important feature of this infectious organism is that it's a beta hemolytic organism, which means that it will cause complete hemolysis of the blood. So here is a blood agar plate that has culture of different organisms. It has culture of alpha hemolytic organisms, gamma hemolytic organisms, and beta hemolytic organisms, which is group A Streptococcus. And here you can see that the zone around the culture has been completely hemolyzed. So complete hemolysis is caused by group A Streptococcus, which is a beta hemolytic organism. And so here I have a table for you, which you will encounter multiple times in your microbiology questions. And so here it shows you the difference between Streptococcus as well as the Staphylococcus organism. Staphylococcus are catalase positive, while Streptococcus is catalase negative. And then the ones that are catalase negative and are beta hemolytic include, for instance, group A Streptococcus and group B Streptococcus. And in order to differentiate these two, you know that the Streptococcus pyogenes is sensitive to bacitracin, while group B Streptococcus or Streptococcus agalactia is resistant to bacitracin. In any case, so important features of group A Streptococcus: gram-positive cocci that grow in chain, bacitracin sensitive, and are beta hemolytic. And so here I have provided you with a memory aid that helps you memorize these features. So I would like you to imagine a gas station that is being connected with a pipe to a nozzle. And so what this image tells you is that group A Streptococcus is made of cocci that are growing in chain, and then the nozzle here, you can see that it has the shape of a beta, and these are beta hemolytic organisms. So group A Streptococcus are gram-positive cocci that grow in chain and are beta hemolytic. And then one other feature was that it's bacitracin sensitive. So here is a review: bacitracin sensitive, grows in chain, gram-positive cocci, and beta hemolytic. And then in terms of the diagnosis for infections with group A Streptococcus, you can obtain a culture of the throat. If they can grow the beta hemolytic streptococci, then that's one diagnostic feature. You can also perform a rapid strep test. So what this strep test contains is antibodies against the antigens that are produced by the group A Streptococcus. And so once the antibodies in this test are reacting with antigens from the group A Streptococcus, it will result in a positive reaction, which would be diagnostic of infection with group A Streptococcus. And then finally, streptolysin O is one of the components of the group A Streptococcus. So presence of antibodies against streptolysin O, also known as anti-streptolysin O antibodies, is also another diagnostic feature for group A Streptococcus. And then for treatment of patients that are infected with group A Streptococcus, you can provide them with oral penicillin. Alright, next I would like to discuss the virulence factors of group A Streptococcus and talk about how any one of these virulence factors can lead to different complications. And so the first virulence factor is M protein, which protects Streptococcus pyogenes from phagocytosis. But then the problem is that there are antibodies that are formed against M proteins, and these antibodies are cross-reacting with the cardiac muscles as well as cardiac endothelium, as a consequence of which it will cause valvular damage, which is most commonly seen in the mitral valve. In addition, the same antibodies can also interact with neurons and cause Sydenham chorea, which is seen with the rheumatic fever. So next, I would like to discuss the rheumatic fever with you. So usually 2 to 3 weeks after pharyngitis, patients can present with rheumatic fever. And then there are criteria for the diagnosis of rheumatic fever, which are called Jones criteria. So any one of the features that I've listed here are considered as major criteria, while the ones that I've listed at the bottom, fever, arthralgia, elevated erythrocyte sedimentation rate, the C-reactive protein, leukocytosis, as well as the prolonged PR interval, these are all considered as minor Jones criteria. So presence of 2 Jones major criteria, like any one of these two, or the presence of 1 major and 2 minor criteria confirms the diagnosis of the rheumatic fever. So the first major criteria includes migratory polyarthritis, and this is actually the earliest symptoms that are seen with rheumatic fever, and it can present as early as the first or second day. And so patients presenting with the redness, pain, and inflammation of their joints, but then once one of the joints resolve, then it will start to present in another joint. So it's jumping from one joint to another, and so that's the reason the name migratory polyarthritis is given to the joint inflammation that is seen with the rheumatic fever. The next condition is carditis, and that's how here I have shown you as in heart. So Jones criteria, instead of O, I have shown you an image of a heart. So carditis is another major criteria for the rheumatic fever. And so the inflammation of the cardiac components, like for instance endocardium, myocardium, as well as epicardium, are seen with the rheumatic fever. And inflammation of the myocardium, this is the most common cause of death in patients with rheumatic fever. The next condition is the presence of the subcutaneous nodules. So there are nodules that are under the skin, and these are most commonly seen over the bony surfaces. And there could be from a few millimeters up to 2 centimeters in size. Next, we have the erythema marginatum, where there would be a macular skin rash that does not affect the face. So this one is a macular skin rash. And then finally, we have the Sydenham chorea, where there would be involuntary movements of the extremities. And as I just discussed earlier, this is also from the cross-reactivity of antibodies that are formed against the M protein. And then rheumatic heart disease, the incidence of which is decreasing due to the use of oral penicillin, is another complication that can arise from group A Streptococcus. And so as I just discussed earlier, antibodies that are formed against M protein, they can interact with the heart endocardium and so cause damage to the mitral valve. After that, aortic valve is the most commonly affected valve, and then after that, tricuspid valve would be affected. So one of the early lesions that you see in patients with rheumatic heart disease is mitral regurgitation. Another feature of rheumatic heart disease is presence of the Aschoff bodies, where there is a perivascular fibrinoid necrosis. And this type of necrosis is surrounded by large histiocytes, which are referred to as Anitzschko cells. So Aschoff bodies where there is fibrinate necrosis that is in the perivascular area, and this type of necrosis is surrounded by large histiocytes known as Anischko cells. The next virulence factor is streptolysin O, which is responsible for beta hemolysis that is seen around the colonies that are grown on a blood agar plate. And as we discussed earlier, presence of anti-streptolysin O antibodies is one diagnostic test that can be used for infections with group A Streptococcus. Next we have streptokinase, and from the hematology section you may recall that streptokinase is responsible for conversion of plasminogen into active plasmin, and then active plasmin break down the fibrin into fibrin degradation products. And it's thought that streptokinase binds to the glomeruli, as a consequence of which now there would be antibodies, IgG, as well as complement molecule C3 that will attack the surface of the glomerulus, and so therefore it will lead to acute post-streptococcus glomerulonephritis. So here I would like to discuss the acute post-streptococcal glomerulonephritis. And this type of glomerulonephritis can result either from pharyngitis or from impetigo, which is skin infection. And in fact, impetigo is a more common cause of post-streptococcus glomerulonephritis. Up to 25% of the cases of impetigo can lead to glomerulonephritis, while pharyngitis, only 10% of these cases can lead to the glomerulonephritis. And then pharyngitis can cause rheumatic heart disease, while impetigo does not cause rheumatic heart disease. And it's thought that it's due to the location of pharyngitis, where there is too much lymph flow that can cause a strong immunologic response to the M protein that can lead to rheumatic heart disease, while impetigo does not cause rheumatic heart disease. In any case, back to the topic, patients with post-streptococcus glomerulonephritis, these patients have subepithelial immune deposits of IgG and C3 molecules. So once again, subepithelial immune deposits. So here it shows you a cross-section of the glomeruli that I draw for you. Blue cells on the outside are the epithelial cells. Then we have the black line, which is the basement membrane, and then inside we have the endothelial cells. And so IgG and C3 deposits would be under the epithelial layer, which is shown here in gray spots. And so therefore it's referred to as subepithelial deposits that have a lumpy, bumpy appearance under light microscopy. As for the clinical features of post-streptococcus glomerulonephritis, these patients present with dark urine as well as periorbital edema. And then one other important lab value you should be aware of is that since there is too much deposition of the complement molecules under the subepithelial spaces, there would be low number of complement molecules in the circulation. So important lab value is that low complement level. And then the final virulence factor I would like to discuss with you is the pyogenic exotoxins A, B, and C. And these exotoxins can act as super antigens, which can lead to the Streptococcus toxic shock syndrome. So next I'd like to discuss Streptococcus toxic shock syndrome with you. So exotoxins can act as super antigens, which can lead to the exaggerated immune response. And I would like to discuss this in a little more detail so you would understand how super antigens work. So I don't want to get into too much details regarding the MHC1 and MHC2 molecules, but in order to understand how superantigens work, I would like to give a quick review of this topic. So there's a separate video in the immunology sections which covers MHC1 and MHC2. So here I would like to provide a quick recap. So MHC1 is seen in all nucleated cells as well as platelets, but not red blood cells. And its function mainly is to mark cancer cells as well as the virally infected cells. And so protein degradation products from these cells, once they present in the peptide binding groove, the MHC1 would be presented on the surface of the cell, and so CD8 positive T cells will recognize the abnormal proteins and start destructing those abnormal cells, which could be cancer cells or virally infected cells. And so that's why it says that the peptide that is bound to the peptide binding group is endogenously synthesized. So it's already synthesized inside the cell and presents on the peptide binding group of MHC1. With MHC2, on the other hand, there is an invariant chain that is present in the peptide binding group. So naturally, no antigen can bind to the peptide binding group. And so MHC2 is present in the antigen presenting cells, like for instance macrophages, dendritic cells, as well as B, and in some organisms T lymphocytes as well. And so what happens is that once there is an endocytosis of an antigen inside the endosome, since there is an acidic pH, the invariant chain would be removed. And upon removal of the invariant chain, there would be now space for the antigen to bind to the peptide binding group. And then from here on, MHC2 will be presented to the cell surface, and then it would be recognized by the CD4 positive T cells. And so since the antigen is being processed from outside, it's being endocytosed from outside, it's said that it's being exogenously processed. So from here on, I would like to discuss how the superantigens work. So this is the mechanisms that I just discussed with you. The antigen is being endocytosed, it's being brought to the endosomes. Inside the endosomes, the acidic pH will allow the invariant chain to remove. The antigen will replace the peptide binding groove, and then from here on, the MHC2 will present on the cell surface and being recognized by the CD4 positive T cells. Now with superantigens, what happens is that they bypass all these processing, and so therefore they would be able to directly link MHC2 with the CD4 positive T cell receptors and mount a severe immune reaction, as a consequence of which patients present with the toxic shock syndrome. So back to the topic. So exotoxin that acts as superantigens can cause an exaggerated immune response, as a consequence of which there would be elevated secretion of interferon gamma as well as interleukin 2, which will lead to shock. So these patients generally present with the hypotension of less or equal to 90 millimeter mercury systolic blood pressure, and they also present with multi-organ failures, like for instance renal failure, as well as acute respiratory distress syndrome. Alright, now could you tell me, in addition to Streptococcus pyogenes, what other infectious agent can also produce superantigens? And the answer is Staphylococcus aureus can also produce superantigens and cause toxic shock syndrome. And this type of condition is usually seen with the use of the superabsorbent tampons. In any case, back to the virulence factors of the Streptococcus pyogenes. We've already discussed that these virulence factors can cause rheumatic fever, acute post-Streptococcus glomerulonephritis, as well as streptococcal toxic shock syndrome. The last condition is scarlet fever, which is from the delayed T-cell reaction against the exotoxins. So type 4 hypersensitivity reaction, also known as delayed hypersensitivity reaction, can lead to the scarlet fever. And then type 4 hypersensitivity reactions require prior exposure to the antigen. So these patients has been previously infected with group A Streptococcus and been exposed to the exotoxins. When there is another infection, there could be a T-cell mediated immune response which can lead to the scarlet fever. And so characteristics of the scarlet fever include skin rash, where there would be a diffuse erythema with small nodules of 1 to 2 millimeter that give it a sand paper like texture. And this type of rash is generally seen on the trunk and neck, but spares the palms and the soles. So the sandpaper quality of the skin is a very important keyword for the diagnosis of the scarlet fever. And then finally, other important characteristic features of scarlet fever include strawberry tongue, as well as sore throat and fever. And that concludes our discussion of the Streptococcus pyogeny infection.